So we'll talk about rectal cancer today, and I think this is timely in the sense that there's been a virtual explosion of treatment algorithms for locally advanced rectal cancer over the last few years, and it's really important to highlight these. So once again, we'll focus on locally advanced rectal cancer. We'll talk a little bit about the demographics. I think to know where we're going, it's also important to understand how we got to this point in terms of the evidence. We'll review that with a particular focus on neoadjuvant therapy and how we developed our evidence and our practices related to that. And most importantly, what's arisen over the past few years is this interest in modulating the different components of neoadjuvant therapy or multimodality therapy, including radiation, surgery, and chemotherapy. And in particular, I will highlight very hot topics right now, which include the watch and wait approach for rectal cancer, but also the whole concept of total neoadjuvant therapy for rectal cancer. So in terms of the customary demographic slide, in 2019 we estimate that there will be about 44,000 new cases of rectal cancer. Combined with colorectal cancer, there'll be about 50,000 plus deaths. As we all know, the death rates are somewhat inaccurate in our national databases due to coding reasons for rectal cancer specifically. So let's look at a case presentation first, and basically I'd like you to just kind of think about how you would manage this in your current practice right now, and we'll see how we'll readdress this at the end of the presentation. But it's a 52-year-old gentleman, relatively young, 4 centimeter mass on colonoscopy. It is biopsy proven to be adenocarcinoma. CAT scan shows no metastasis. Importantly, in terms of our current standard of care staging using MRI with rectal protocol, T3N1, clear predicted mesorectal margins and no extramural vascular invasion noted. And on physical exam, we see a 4 centimeter diameter left anterolateral rectal mass, 2 centimeters above the anorectal ring, so very close distal rectal cancer, and but with patient has excellent sphincter function. So in the early 1900s is when we first describe rectal cancer surgery with curative intent. This has been attributed to Sir Miles, for which he holds the eponym for the APR back in the day, the Miles procedure. And remarkably, up to the most part of that entire century, up to the 1980s, surgery alone remained the standard of care for rectal cancer. What was a problem here? The local failure rates were terrible. 25%, a quarter patients of stage 2 were recurring, up to 50% of stage 3 cancers were recurring, and this was certainly before the pre-total mesorectal excision era, but these recurrences were debilitating. So how were we hoping to address this? So this was the algorithm, quite remarkably. So the question was, could additional treatment after surgery improve outcomes? And so NSABP-R01 tried to address this with the addition of either chemotherapy or radiation after surgery, and this obviously is a randomized trial. The take-home message here was that surgery plus radiation really reduced local recurrence from 25% to 16%, and that the chemo actually improved survival outcomes. The other landmark trial was the GIT 67175 trial with a randomization to 4 arms, and in this case, radiation, chemo alone, but now combining in multimodality fashion radiation and systemic chemotherapy for the first time. And this radiation chemotherapy multimodality arm was very significantly advantageous in showing improvements in 5-year disease-free survival, overall survival, and local recurrence. And finally, the last important trial from this era was the NCCTG trial, which looked at patients treated with surgery plus radiation alone, or surgery plus, once again, a multimodality arm of radiation and systemic chemotherapy. Adding the radiation and the chemotherapy improved local recurrence, disease-free survival, and certainly overall survival. So from about 1990s to the early 2000s, there's a period of relative stability, as we say. This particular treatment algorithm was advocated for by an NIH consensus conference, and the results of which were published in 1990. So once again, using adjuvant chemotherapy and adjuvant chemoradiation after surgery. So we still had problems with this approach. Local control was still not optimal. The treatment-related toxicity, both in the acute and chronic time periods, were of concern. Bowel function certainly was a problem long-term, and still we were not optimizing sphincter preservation in many patients. So how about using neoadjuvant chemoradiation? Would this be of some help? So what were the considerations of applying chemoradiation before surgery? So some of the advantage, or theoretically, would be that micrometastases could be treated earlier in the course of disease. As many of you know, however, the chemotherapy and chemoradiation is somewhat radiosensitizing, not really true systemic. Nonetheless, efficacy may be higher in the setting of an intact vasculature in terms of delivery, for example. The risk of tumor seeding during surgery may be reduced, and giving it prior to the surgery may result in a reduced acute and chronic toxicity, and you're taking out that irradiated bowel, so perhaps there'd be improved bowel function. And with tumor shrinkage, one would anticipate enhanced sphincter preservation. Some of the concerns about this approach back then was perhaps a tumor could progress prior to definitive surgery, and then inaccurate staging could lead to significant overtreatment of some patients. So the important trial back at this time, and I remember this, and I date myself because I presented this at Journal Club when it came out when I was a resident, but this was the Swedish rectal cancer trial. It's important to note that in Scandinavia, they're using a different radiation regimen. Many of you are familiar with it now as the 5x5 short course radiation. But this was the first trial to really apply this in the neoadjuvant setting. So it was surgery versus neoadjuvant short course plus surgery. Remarkably, the local failure rate was dramatically reduced in patients in the short course radiation arm. And in this case, this was very significant in that overall survival was also impacted with this particular approach. The criticism for this paper was the fact that the surgery was non-standardized, non-total mesorectal excision surgery. As you know, TME surgery was described by Dr. Bill Heald in the early 1980s, and talks about the technical aspects of removing the entire sheath of mesorectal fat along with the rectal resection. Despite being described in the early 1980s, as you all know, this took about a couple decades to really achieve full dissemination and adoption worldwide. But the take-home message from this was that the recurrence rates from the local standpoint were reduced to about 10%. This in itself was revolutionary. The Dutch rectal cancer trial addressed this issue of incorporating TME surgery plus the short course radiation therapy, as was done in the Swedish rectal cancer trial. Even in the setting of really good optimal surgery, the preoperative radiation reduced local recurrence by half. So this was once again very significant. In North America, at the same time, we were very interested in applying our own approach, which was the conventional chemoradiation, not the short course. We had two trials that were initiated, NSABP-R03 and RTUG-9401, but sadly these were closed due to lack of accrual, so we hadn't answered this question on our home turf. Fortunately, the German rectal cancer trial was conceptualized and used regimens that were very similar to what we use here in North America, and this was a randomization to pre-op long-course chemoradiation followed by surgery, or surgery followed by post-op long-course chemotherapy and radiation. The results were very important and formed the foundation of what we have been doing for many, many years, and if there's any trial for the trainees to remember, it would be this one. Local recurrence rates were reduced significantly with pre-op approach. Acute toxicity, chronic toxicity were also reduced with the preoperative approach. And finally, sphincter preservation was significantly enhanced with the use of neoadjuvant long-course chemoradiation. Even though overall survival was not necessarily impacted by the preoperative approach, these significant, these significant advantages allowed us to adopt this as our preferred approach. So we did have neoadjuvant radiation as part of our algorithm now. There still was some of that nagging question as to was short course or long course better for the treatment of our patients. The Polish rectal cancer trial number 1 addressed this. They looked at pre-op short course versus pre-op long course. The issue here was that it was criticized due to the fact they used bolus 5-FU. Kind of our standard has always been infusional 5-FU. The overall survival and disease-free survival, the outcomes were generally quite similar. Acute toxicity was somewhat appeared to be reduced in this trial in the short course arm. The TROG study from New Zealand and Australia looked at this same question but used regimens that were quite similar to ours. Essentially, the recurrence rates as well as the survival rates were essentially quite similar, showing that both approaches were potentially equivalent. Even though they showed no difference in toxicity, this has been a very strong concern of North American radiation oncologists. So if you look at this chart, I think one would say that between neoadjuvant short course and long course, efficacy is probably similar. Sphincter preservation is in favor of long course, allowing for shrinkage of tumor. Acute toxicities appear to be the same. Late toxicity appears to be in favor of long course. There appears to be some studies showing some increased long-term toxicity related to short course radiation, but certainly convenience and cost are substantially better for short course. With all these considerations, including some potential bias, I would say, in our North American regimens, we've gone to this preferred approach. I add a multidisciplinary component to this in terms of a multidisciplinary discussion and decision making, but this has been the standard post-German rectal cancer trial here in this country. The other question that has arisen, which is important to us surgeons, which I get asked about a lot, is how long should we wait between chemoradiation and surgery? And so this has become an important question as well. Several retrospective studies looked at this question. The Dutch database looked at this and showed that the peak and plateauing of complete pathologic complete response was about 10 to 11 weeks after long course chemoradiation. And during this time period, the longer you waited, there appeared to be greater pathologic complete response rates. Probst and others looked at the our NCDB database and compared surgery from less than 6 weeks or greater than 8 weeks to between the standard 6 and 8 weeks. Waiting to greater than 8 weeks had higher rates of path CR, and similar to the Dutch study, the peak path CR rates were about 10 to 11 weeks, suggesting perhaps there's not a lot of reason to wait beyond that. There has, in fact, been a randomized trial called the GRECAR-6 trial from France, which looked at 7 versus 11 weeks of waiting prior to surgery. Interestingly, they showed that there was no significant difference in the path CR rates, but in somewhat provocative fashion, they did observe that the morbidity may be higher in patients operated 11 weeks, and the complete TME rate or the quality of surgery may have been diminished by waiting longer, and this is somewhat controversial. So at this point, we maintain a standard of care framework here, which has kind of been in place since the early 2000s. And this is the framework by which many of us have been looking at, or various investigators have been looking at modulating the various components. So for radiation, can this in fact be eliminated? Surgery, can we do lesser surgery? Can we even eliminate surgery, heaven forbid? And then in terms of chemo, can we attenuate the chemotherapy, or can we alter the sequence in which it is given? So let's talk a little bit about radiation. What about removing radiation? So the first study that really brought this to our attention, which was quite dramatic, was the study by Dr. Schrag and her colleagues from Memorial Sloan Kettering. This was a small pilot study of 30 patients in which they did not give radiation, but instead just gave chemotherapy prior to surgery. And this was using FOLFOX and bevacizumab followed by FOLFOX, but it should be noted that they ultimately went to just FOLFOX and did not use bevacizumab. Regardless, 30 patients were studied. All patients had some degree of tumor regression and went on to radical surgery. The pathologic complete response rate with chemo alone was 25%. This is quite remarkable. This is equivalent to what we see with 5-FU and radiation, so quite interesting. No recurrences and good disease-free survival. This brought additional interest internationally. A trial from China called the FOWARC trial was initiated and completed. They randomized patients to basically a standard chemoradiation surgery chemo arm. kind of a oxaliplatin-associated chemoradiation arm, followed by surgery, followed by chemo, and most importantly, a chemo-only arm for locally advanced rectal cancer. The outcomes are essentially similar across the board, and the important take-home message from this trial was that FOLFOX alone had identical outcomes compared to standard 5-FU radiation. So this was quite remarkable thinking, certainly. So in our country, we're waiting for the results of the PROSPECT trial. Many of you are probably aware of this. Many of you probably have participated in this trial as well. There was a standard arm to this, but the experimental arm went as follows. You got your chemotherapy. There was a safety net here. These patients were restaged. If you have a great response, you went on to surgery alone and you were able to emit radiation. However, if you did not respond well, you went into standard chemoradiation. So the accrual has been, in fact, completed here, and we hope to have those results in the near future. And this was also run by Dr. Schrag and colleagues. So how about surgery? Can we reduce the extent of surgery following chemoradiation? For example, instead of doing radical surgery, can you do some type of local excision here? So our group, one of our fellows published this, and we were quite interested in this. And back at this time, this was one of the largest studies of this nature, albeit retrospective. But basically, the message here was that you could do local excision after chemoradiation, and had very low recurrence rates, and the overall survival rates were very similar to that with radical surgery. These were very highly selected and retrospective, however. A prospective study was done in very similar fashion. This is called the CART study from the Netherlands, looking at patients receiving neoadjuvant chemoradiation. If you had a good response, being T0 or T2, or I guess some degree of response, these patients were treated with transanal endoscopic microsurgery. Local recurrence rate was 7.7%, and disease-free survival and overall survival rates were would rival those of radical surgery. I think the important thing that this group highlighted here was that using a low anterior resection symptom score, they found that these patients, even treated with local excision, had pretty bad bowel function. And this may be related to the fact that some of these tumors that they treated in this fashion may have been larger than many of us would usually tackle. There has, in fact, been a randomized trial looking at this particular issue. This did have some problems, however. I'd like you to focus on this little corner over here. Patients who had a good response went to local excision or total mesorectal excision. However, there appears to be a selection issue here because they had a bunch of patients that did not really have a good response and then ended up getting TME. So although this trial failed to show superiority of local excision, this was kind of confounded by the fact that many patients end up getting a TME. So they concluded that perhaps better selection criteria were required for this particular approach. So the take-home message here, certainly this wouldn't be considered necessarily standard of care, but could be a potential option for patients with a partial clinical response after neoadjuvant chemoradiation that perhaps are refusing APR, perhaps that are not good candidates for radical surgery. But with further development, could be an approach for patients who are not necessarily candidates for a watch and wait approach, which we'll talk about soon. So let's talk about watch and wait, and this certainly illustrates the issue that perhaps not every nail needs a hammer. So the watch and wait approach has really gotten some significant traction over the last several years, and I also have some visceral disturbances watching surgery come off the page as well, but it is certainly a viable approach these days as we're seeing. So in the early 2000s, this is not a new concept, and many of you are well aware of the Brazilian group led by Dr. Habergama, who presented some very provocative data back in that day, and looking at patients who had an excellent response after chemoradiation and showing that these patients could potentially be observed. Very low recurrence rates and survival rates that were absolutely similar or even better than patients having radical surgery and having a pathologic complete response. Many of you who were involved in those discussions saw a lot of skepticism, and I certainly give them a lot of credit for continuing to advocate for this potential approach. This led to a number of prospective type approaches in which, with small numbers certainly, but a group from the Netherlands showed 21 patients with 1 local recurrence, very good comparable survival rates compared to those with radical surgery. A group from Denmark, in similar fashion, looking at 40 patients, local recurrence rates about 22%, but once again, this is they were looking at trying to avoid APR for these patients. This has certainly led to international consortia. The ENCORE project assembled a group of 129 patients managed by watch and wait. The 3-year local recurrence rate was 38%. However, 88% of these were actually salvaged with radical resection. They did a propensity score matched analysis comparing 109 resected patients and found that overall survival rates were essentially similar. However, the colostomy-free survival rate was much better in those patients managed with watch and wait. An even larger international registry was created, looking at compiled 880 patients, 2-year local recurrence rates of 25%, 8% distant metastasis rate, and once again, very comparable overall and disease-free survival rates compared to radical resection. However, given this, I'd leave this particular section providing some food for thought. This is the experience reported by Memorial Sloan Kettering. This just came out last month. It's led by Dr. Pat Patey, who's been a proponent of this particular approach over the past several years. They look at 113 patients which they treated in this fashion with a clinical complete response with watch and wait. 22 local recurrences, 91 successfully managed with watch and wait. And they did have a kind of a comparative resection arm with 136 patients shown to have a pathologic complete response. The very interesting and somewhat concerning observation here related to distant metastasis. If you look at your radically resected patients with a path CR, the distant metastasis rate was 4%. For those that were successfully managed by watch and wait, 1% distant metastasis rate. However, for those patients that experienced a local recurrence, the distant metastasis rate was 36%. That is certainly alarming and raises questions about biology. Were these cases going to become metastasis regardless, or did the local recurrence actually facilitate the development of distant metastasis? These are important questions that clearly need to be answered as we move forward. So take-home message here for surgeons, certainly, these are promising results. However, we have to acknowledge that there are absolutely patients that do not require surgery, but the patient selection issue is what is critical at this point. This therefore may not be entirely ready for prime time or standard of care, and further clinical trials are ongoing that address this issue. So let's look at the whole issue of chemotherapy. We have to understand how we apply adjuvant therapy for locally advanced rectal cancer. We don't have the clean clinical trials as we see for stage 3 colon cancer, and there's a bunch of mixed conclusions with respect to systemic reviews and meta-analyses in this particular situation with rectal cancer. So we do extrapolate from colon cancer data. Currently, 6 months of perioperative chemotherapy is common practice in most of our centers, both here and internationally. Most patients will get 2 months of credit for the chemoradiation that they receive, but we do all acknowledge that it is not full systemic therapy, and 4 months of post-op. There's some interest in potentially reducing the adjuvant chemotherapy as per what's being done in colon cancer now, where for low-risk colon cancers of stage 3, we are reducing from 6 months to 3 months. So we'll stay tuned with respect to how we apply for rectal cancer. Now, the rationale for adjuvant therapy, I probably don't need to review this for this crowd, but it's to sterilize micrometastatic foci, prevent metastatic tumor spread, and in this fashion improve survival. For rectal cancer, as you all know, adjuvant therapy becomes a bit of a problem for chemotherapy. There's a high risk of complications compared to colon surgery. Many patients may not actually get to chemo, and the reversal of diverting ostomy in many patients is extremely pressing, whether it's actually for physical reasons or even psychological reasons. So non-receipt, delays of therapy, dose reduction can all result in reduced efficacy. And these issues were absolutely highlighted by a number of studies. It's quite remarkable in terms of the data. A quarter to half of patients actually don't get the planned course of adjuvant chemotherapy following neoadjuvant chemoradiation and surgery for rectal cancer. The initiation of timing within 8 weeks is associated with improved outcomes. Interesting, it's estimated that every 4-week delay results in a 14% reduction in survival, and even early discontinuation of chemotherapy is associated with worse outcomes. So with that in mind, can we alter the sequence of chemotherapy to try to mitigate these issues? One approach is total neoadjuvant therapy, or TNT, great acronym, in which you can actually put the chemotherapy before chemoradiation and surgery. This would be induction chemo TNT. The other approach would be bringing the chemo just before the surgery and after chemoradiation. This would be a consolidation chemo type of TNT. The latter induction type has been studied a little bit more. So what are these considerations that allow us to do this, or why should we do this? So once again, as we discussed before, micrometastases could be treated early. As surgeons, one could appreciate the fact that giving all the therapy before the surgery would allow for a full postoperative recovery without the worry of diving into chemotherapy. For many patients as well, the earlier reversal of a diverting ostomy is extremely desirable. We can also facilitate sphincter preservation with perhaps maximal shrinkage of tumor. We can also, in this day and age, maximize opportunity for a watch-and-wait approach. And certainly at this point now there's a vacant treatment space now after surgery, and perhaps this would allow for the study of novel adjuvant therapy regimens for high-risk patients. There are certainly considerations that raise concern as well. The risk of progression with chemoresistance. Perhaps there's a true risk of overtreatment in these patients, and we absolutely have to have accurate staging. And toxicity may actually end up precluding surgery in some patients. In terms of the particular modulation of the sequence of induction versus consolidation, induction chemo would allow for evaluation of response after chemotherapy with possible elimination of radiation, but there is certainly a theoretical concern of inducing radioresistance. In terms of consolidation chemotherapy, it could allow for active treatment during that interval that you wait between chemoradiation and surgery, and could maximize the potential for complete response. The Spanish GCR3 study looked at this with a randomized trial. They had a TNT arm compared to a standard chemoradiation surgery adjuvant therapy arm. What they showed here is that the oncologic outcomes were essentially the same. However, and quite dramatically, they showed that the completion of systemic chemotherapy in the TNT arm was 94% compared to half in the standard arm. And chemo-related grade 3-4 toxicity was only 20% compared to 54% for the TNT arm. Even though the oncologic outcomes are similar, these dramatic findings suggest that this was a viable treatment algorithm that we could study further. Talking about consolidation chemo, TNT, Dr. Garcia Aguilar from Sloan Kettering came up with a very innovative trial in which they looked at giving chemotherapy after the completion of chemoradiation and prior to surgery. They had 4 arms. In groups 2, 3, and 4, they added progressive cycles of chemotherapy prior to the surgery, 2 cycles, 4 cycles, and 6 cycles. The primary endpoint here was pathologic complete response rate, and as you go from group 1 to group 4, you can see that the pathologic complete response rate improved significantly during this time. An important point that Dr. Garcia Aguilar and his team made was that there were no greater technical difficulties as we waited longer, and no increase in postoperative complications, which kind of went against what the GREC-R6 trial had shown. There's still a bit of a nagging point about the short course radiation component, is there an opportunity for short course TNT? The Polish Rectal Cancer 2 trial looked at this particular question. They made a kind of an abbreviated TNT course here and showed actually that short course TNT was better than what they described as conventional long course therapy. This was criticized to some degree given the fact that they once again continue to use bolus 5-FU. We are awaiting the trials of the Rapido trial from Sweden. They recently reported that they've actually randomized 900 patients to either conventional chemoradiation arm or short course TNT with more substantial chemotherapy, and once again they used a conventional chemotherapy radiosensitizing component, and we hope to see these results in the near future and should provide some additional information about how we apply short course TNT. I'd be remiss if I didn't talk about this particular North American trial based out of the NRG Cooperative Group, and this is run by Tom George from the University of Florida. This is quite innovative and a very interesting study design. They have a standard TNT arm for patients with locally advanced rectal cancer with FOLFOX, chemoradiation followed by surgery. This is a single comparative control arm that is being used for all subsequent arms. They will be adding additional arms moving forward, applying novel agents as they become discovered, applying novel hypotheses as they become developed. And for example, the first arm they're looking at here is the standard arm, but using a PARP inhibitor for radiation sensitivity. So this is really interesting, and we certainly look forward to seeing the additional arms that come through. Finally, a very innovative trial from the Sloan Kettering Group, once again, is the OPRA trial, the Organ Preservation and Rectal Adenocarcinoma trial, and they look at two different components of the issues that we've been discussing. One is the comparison between induction versus consolidation TNT, and as well, looking downstream, applying watch and wait. So what they do here is they randomize patients to either induction TNT or consolidation TNT, and based on the response, they will get radical surgery, or they can go on to a watch and wait approach. So there'll be some very interesting results that come out of this. I'll finish this whole section here talking about the NCCN guidelines. If the NCCN guidelines page was available in the 1980s, you probably would have seen 3 words: rectal cancer, arrow, surgery. This has become remarkably complex now in terms of our decision making. We certainly recognize and acknowledge the potential of using short course radiation therapy for these patients. The TNT approach is now recognized as a viable option, certainly. And now, finally, this with the past guidelines, we've introduced watch and wait in the footnotes, certainly. It is not necessarily standard of care, but is being recognized as something that could be considered with a multidisciplinary approach. So really complex decision-making going on now. We'll go back to our patient, T3N1, with a threatened sphincter. The patient course went as follows. Rectal cancer was diagnosed. We did a multidisciplinary discussion. In this case, we decided that for this young patient with good sphincter function and the clear desire to avoid a APR, we would go for a maximal response. We used a TNT approach. We re-evaluated in between chemo and chemoradiation, saw that there was a good response but not complete response. We went ahead with chemoradiation as well. There was still an incomplete response, but this patient was able to get a low anterior resection with a coloanal anastomosis, had early ileostomy reversal, and is now in surveillance. So completely different from what we have done 2 years ago, and there's multiple algorithms that could have branched off depending on the patient's response. So in conclusion, for locally advanced rectal cancer, there is in fact a revolutionary growth in management options now. It's become increasingly complex. More than ever, the multidisciplinary collaboration is critical. There's now an increasing opportunity for personalization of treatment for these individuals. We can maximize treatment, or we could even selectively modulate or even omit certain components of multimodality care. We have to harmonize these with the patient's projected toxicity, quality of life, and function. The opportunities for further knowledge include improving patient selection. Can we incorporate improved imaging for staging and restaging? And can we develop molecular biomarkers that would allow for prediction of treatment response? I'll finish talking a little bit about what we see as the surgeon's role here. I think we play a critical role in the multidisciplinary tumor board and have to be actively engaged. For those patients that are not directly referred to us, we have to insist on seeing patients prior to any treatment. This allows us to assess the status and potential for sphincter preservation from a technical standpoint, from a functional standpoint, and certainly for the patient, an occupational standpoint. We can even estimate and begin discussions with the patient about the potential psychological and physical tolerance of an ostomy, whether it's temporary or permanent, and even decide whether patients can tolerate radical surgery. These are such important components to decision-making now, and we're the only ones that can provide that. We have to be engaged in the interval follow-up of these patients at various treatment junctions. And certainly, we have to educate our peers. I must say I'm occasionally still seeing patients who are unstaged with rectal cancer having been treated with surgery up front, even in this day and age. And so really we play a critical role in dictating and even altering treatment selection and course for our patients, and knowing about all these options really serve our patients well. Thank you very much for your kind attention. Be delighted to answer any questions.